I'm going to present the area of financial barriers. I'm an economist by training, and all of my research in the last 18 years has really focused on disparities in treatment and outcomes due to differences in socioeconomic status, differences in health insurance, as well as race and ethnicity. And I've also focused on employment and employment outcomes. So this talk is going to integrate a little bit of my own research in terms of the background and also present the priority as we go forward. Okay, so this is about financial barriers. And nearly every speaker that we've had has touched on financial barriers and the importance it has to individuals who have not yet been diagnosed with cancer but need to think about prevention and screening and early detection. There's barriers for financial barriers and insurance-related barriers in order to get the preventive care, the early detection services, and then once diagnosed with cancer, to get the needed services and the treatment. And then afterwards, so this is a place where financial barriers touches the entire cancer continuum. Afterwards in survivorship, those financial consequences continue. So Randy showed fabulous slides earlier in the graphs of the differences by those who are Medicaid or publicly insured or uninsured, and differences in screening rates. And if you looked at differences in cancer stage and diagnosis, you would see the same kind of disparities. But it doesn't end once they've been diagnosed and treated. It goes well into the survivorship period with ongoing financial issues. Collecting data in order to understand how you make progress in this area is a challenge. We haven't historically done that. There's been primary data collection to talk a little bit about financial barriers, but we haven't really captured that. There's some data that's available through secondary data sources like the Cancer Registry, that looks at health insurance status at diagnosis, but really our entire proxy around barriers and disparities has been health insurance or race and ethnicity. And then to be able to show those differences. But we're not really getting at the issue of financial barriers and what that causes. What we know is that it's not just the cost of therapy and the access barriers, but afterwards this employment effect that goes on as well. So some of the studies that I've done in the past have looked at employment impacts of individuals, women who were diagnosed with breast cancer, got their health insurance at that time solely through their employer. They don't have an option to quit. They have to continue to go on to continue the health insurance benefit. Now that we have the Affordable Care Act, it's been expanded to Medicaid expansions for the states that expanded Medicaid. Colorado is one of them that has, and offer an access to health insurance outside of an employer-based mechanism. But that doesn't solve the problem, because what we've had now is a shift and a change in how we organize health insurance. Most plans are now high deductible plans. So when you have a high cost disease, those high deductible plans can still be tremendous amounts of cost there. So we've changed the problem, but the problem still exists, and it isn't taken care of just by making more insurance available. The other thing is, as we've improved these new treatments, and treatment has improved and they've changed survivorship quite a bit, those treatments are outrageously expensive. So we continue to hear more and more in the news about the cost of new therapies. So we're applauding the availability or these drugs coming on board, but the cost of them is often prohibitive for individuals with the disease. And it's understanding now that they have insurance that doesn't solve the problem, and that we have these kind of competing demands. So why should we prioritize this area of work? We have to raise the bottom. We're going to really make a difference in incidence and mortality. We have to focus on this lower group. And like I said, Randy's slides did an excellent job of being able to show those disparities. We have to raise the bottom. Across every single priority, everything that we do, we have to think about people who are at the bottom of that spectrum and are not getting the same benefit. And that if we look at the slides of survivorship and incidence and stage of diagnosis by those who are minorities, uninsured or underinsured, and have these various access, we would see that very little progress has actually been made in those particular groups. Some objectives that we can think about is expanding survivorship planning to actually include financial barriers to get providers involved in terms of educating patients about how much this is going to cost and have that be part of the discussion going forward. To help individuals find access to overcome healthcare, overcome financial barriers in order to get the care that they need. And then to incorporate, and like I said, across all of our priorities, to make sure we focus some portion of our work on those that have disparities or less financial access to care. Questions? Dennis?
How do you think the coalition or a task force related to finance could have an impact? Where would we focus the energy and leverage? How do you see that working?
So I think it's in a couple of different places. One is for the other objectives that we have, that we don't just say we're going to increase screening, but we're going to increase screening among low-income individuals. That's an intentional part of what we do. If it's increasing education about certain sites of cancer and prevention, we focus on this lower income group, that's an intentional part of what we do. Not just that we spread the word, but that we really target these pockets of the population that have been left behind. So I think it's putting that as part of the intent of how we go forward. When we think about survivorship, there have been studies that show the financial burden. Those who experience financial burden as part of their cancer treatment have lower survival relative to others and lower quality of life. If you're already financially strapped, cancer doesn't improve the situation. You can go into a cancer diagnosis not financially strapped and come out of it. Out of reasons for bankruptcy, health-related causes is the #1 reason, and out of those, cancer-related bankruptcies is the highest among healthcare causes.
That focus has been with us for many years. The focus on uninsured, underinsured, low-income people for screening. How would you suggest that this coalition improve upon that?
How do I suggest? So that is a focus. So when you say it's been a focus, has it been a separate one or a component of all the other priorities?
I would say that in most cases it's been a primary focus.
Okay.
Focusing on disparate populations and low-income populations in particular. I don't know if other people would agree with me, but I think I would say, at least in breast cancer, that has been the case.
I would say, and so not knowing your history, but I would say in general, breast cancer is the one place that the most progress has been made on disparate populations, that we've been able to do the most because there's so much awareness. I think having that across the board to other sites, other conditions, and to focus it not just on screening, but really on the survivorship component, the treatment component, all of it, and let it stretch across everything that we're doing. It's really critical, like I said, we have to bring the bottom up and to be able to integrate it across the different priority areas.
I was wondering, are you also going to be looking at the area for the working ladies? Because when we did a study, there are a lot of ladies that are working, so they don't fit that under income types guidelines, but yet they're being impacted tremendously financially. So are we going to be also looking at that population?
Right. We certainly need to. That's an area where the majority of my research has been around employment, the employment impacts of cancer. We have 25% of the people who are not able to return, and many of these new immunotherapies, which is hailed as a new real progress made in cancer survival, have serious debilitating side effects that we have to think about, and individuals need to understand better what the work impact, and it's part of the quality of cancer cares that think about this. Because as I said in the last study, I looked at people who are insured, and these were insured, employed, very well educated individuals that had to remain at work during treatment. Plus, most survivors want to return to work. It's a lot about how they define themselves and their purpose. So it does have to be considered, not just, the financial barriers isn't just at the low income. Excellent point.
So as we're talking about the Medicaid expansion of the socioeconomically disadvantaged, I'm wondering if you can address the issue that we find in public policy, providers taking Medicaid because it is such a difficult environment, plan, if you will, to work through.
Yeah, it is. So providers, the issue here is that providers, in spite of expanded Medicaid, doesn't mean they expand their patient pool that's covered by Medicaid. They still are reluctant to treat these patients. So one of the things that's been done to address that issue is that the fees have increased for Medicaid providers above and beyond. That's a temporary measure. It's a component of the Affordable Care Act that's supposed to sunset. But initially, it was to entice providers to start taking more Medicaid patients as more Medicaid patients flooded the patient panels. There has been an increased access as a result, but whether that will continue once the fee structure goes down, and it's still not perfect. Providers limit, in general, the number of Medicaid patients they will take across the board. There's only so many slots. And for really expensive treatment, so I can give you an example from the state of Virginia, and I was at a safety net hospital health system. They only do one bone marrow transplant per year to a Medicaid patient. Only one slot. And then Medicaid often is paid for clinical trials and also created another barrier. But safety net institution only provided one of these a year to one Medicaid patient.